So today we are going to discuss about ILD associated with systemic sclerosis. So most common pattern of involvement is non-specific interstitial pneumonia (NSIP) pattern. The usual interstitial pneumonia pattern (UIP) pattern seen in IPF is less common in systemic sclerosis. Principal forms of lung involvement in systemic sclerosis include ILD and pulmonary vascular disease, and these two account for majority of the systemic sclerosis related deaths. Okay, incidence of lung cancer is increased in patients with systemic sclerosis, so their cancer risk is also increased. Evidence of ILD can be found in up to 65% of systemic sclerosis patients. Note down, 65% of systemic sclerosis patients evidence of ILD can be found by HRCT, but clinically significant ILD develops in 16 to 43%. Clinically significant means symptoms like shortness of breath, those dry cough. Okay, and risk factors for ILD in systemic sclerosis include male sex, African American race, diffuse skin involvement, severe gastroesophageal reflux, presence of topoisomerase autoantibody. So topoisomerase 1 antibody presence is bad prognostic marker. In contrast, anti-centromere antibody positive patients have reduced risk of ILD. So note it down. In contrast, anti-centromere antibody positive patients have reduced risk of ILD. A reduction in DLCO that is significantly out of proportion to reduction in lung volume should raise suspicion of pulmonary vascular disease, but may also be due to anemia. So when you see reduction in DLCO, diffusion in lung capacity of carbon monoxide that is significantly out of proportion to reduction in lung volume, there should raise suspicion of pulmonary vascular disease. Okay, now we are going to discuss about pulmonary vascular disease. Pulmonary artery hypertension develops in 8 to 12% of patients with systemic sclerosis. So about 10% of systemic sclerosis, pulmonary hypertension develops. Pulmonary arterial hypertension is defined as hemodynamically definition mean pulmonary artery pressure greater than 25 mmHg with pulmonary capillary wedge pressure less than 15 mmHg with pulmonary vascular resistance greater than 3 Wood units, and 3-year survival of systemic sclerosis patients with untreated pulmonary hypertension, artery hypertension is less than 50%. So you can see this is bad prognostics of this pulmonary hypertension. Once pulmonary hypertension develops, it signifies bad prognosis. And presence of anti-centromere antibody is a risk factor for pulmonary artery hypertension in systemic sclerosis, unlike anti-topoisomerase antibody which we saw previously. And Doppler echo provides a non-invasive screening method for estimating pulmonary artery pressure. So if you do catheterization, that is invasive method, and Doppler echo can provide estimate of pulmonary artery hypertension non-invasively. In light of poor prognosis of untreated PAH and better therapeutic response in patients with early diagnosis, all systemic sclerosis patients should be screened at initial evaluation for pulmonary artery hypertension, followed by annual evaluation. So if we treat in earlier stage, so patient can improve and can have good prognosis. That's why we have to screen at initial evaluation and followed by annual evaluation with Doppler echo. Okay, an isolated decline in DLCO may also be indicative of developing pulmonary artery hypertension. This point was also mentioned previously. As I told you that if there is reduction in DLCO that is significantly out of proportion to reduction in lung volume, you should raise suspicion of pulmonary vascular disease. And the same point is repeated here as well. Serum level of NT-proBNP correlate with presence and severity of pulmonary artery hypertension in systemic sclerosis as well as survival. So this also correlate with the presence and severity of pulmonary artery hypertension in systemic sclerosis as well as survival. While NT-proBNP can be useful in screening for pulmonary artery hypertension and in monitoring response to treatment, elevated levels are not specific for pulmonary artery hypertension and can also occur in other forms of right and left heart disease. We know that. So ILD is leading cause of death in systemic sclerosis. Systemic sclerosis associated ILD is not necessarily progressive. It is important to identify patients who are at high risk for disease progression in absence of treatment. Extent of ILD on HRCT and forced vital capacity at initial evaluation, and decline in pulmonary function test during the preceding 12-month period are helpful in identifying these patients. Patients at high risk for ILD should be monitored by performing pulmonary function test every 6 months. Serial HRCT is not recommended. Okay, oral cyclophosphamide for 6 to 12 months and mycophenolate mofetil slowed decline in lung function and improved symptoms. In certain patients who show continued progression of ILD despite medical therapy, lung transplantation might be considered as a life prolonging procedure. Now we are going to discuss about treatment of pulmonary hypertension, because pulmonary artery hypertension accounts for 30% of death in systemic sclerosis. Okay, because PAH is asymptomatic until advanced. Patients with systemic sclerosis should be screened at initial evaluation and annually thereafter. In treatment, we start with endothelin 1 receptor antagonist like bosentan or phosphodiesterase 5 inhibitor like sildenafil. Recently, soluble guanylate cyclase stimulator riociguat. This is guanylate cyclase stimulator, and it acts by increasing production of nitric oxide and dilates blood vessels. And selective IP prostacyclin receptor agonist, Selexipag. Okay, Selexipag were shown to improve pulmonary artery hypertension symptoms. Patients may also require diuretic and digoxin. Prostacyclin analogs such as epoprostenol or treprostinil can be given by continuous IV or subcutaneous infusion or through intermittent nebulized inhalations. Combination therapy with different classes of agents acting additionally or synergistically is often necessary. So this is about systemic sclerosis manifestation in the form of ILD and pulmonary artery hypertension. And now I am going to show you one picture chest X-ray. This is chest X-ray from real patients of 71-year-old male known case of systemic sclerosis presented with shortness of breath for few days, and his chest X-ray is like this. Okay, so you can see this some forms of interstitial lung disease, and if you do HRCT chest, we can definitely see whether it is NSIP pattern or UIP pattern and can delineate from there. But here in up to now HRCT is not done, and I will inform you about HRCT after we'll get the HRCT. Okay, so and about this patient, this 71-year male has systemic sclerosis for about 5 years, and his digital digits 2 to 3 digits are also lost from his hands due to gangrene. You know, the Raynaud phenomenon occurs in digits. Okay, and so digits are also lost in this patient, and this patient also had alopecia with vitiligo also, prominent vitiligo on a scalp and chest region. So there is some autoimmune disease. This vitiligo is also autoimmune disease, and this might be associated. In how much percentage of patient vitiligo is associated exactly, I don't know. If you know, you can comment it down. So you can see this patient now. I have recorded the video of this patient, and you can see the features in this patient. Okay, and I have taken written informed consent about displaying this video in public media. Okay, thank you.
अनि यो औँला यस्तो कहिलेदेखि भएको?
यो 67 सालमा भयो काटेको यो
67 सालमा के भयो त्यो कालो कालो भयो थियो
रातो कालो भएर दिगो हुँदै भएर काटी बढी
यो रोगको कारणले भएको स्किन डिजिजको कारण। अनि फेस पनि त्यस्तो चेन्ज भइसकेको छ है? यो कपाल यस्तो भएको कहिले भयो? कति भयो?
67 साल।
67 साल।
यो पनि अलिक साह्रो साह्रो छ यी छाला
यो पनि साह्रो साह्रो छ कपाल त पुरै पहिलादेखि नै झरेको हो कि यस्तो
पहिला त अलिकति हल्का थियो कि तर हल्का चाहिँ यस्तो नै थियो होइन तर झर्न थालेको यो पछि नै हो पहिला त वंशानुगत बुढै थियो अगाडि चिन्डे अलिक निकै नै थियो कि भाइको पनि त्यस्तै छ तर यो अहिले चाहिँ छालाले गर्दा स्किन डिजिजले गर्दा नि साह्रो साह्रो छ क्या
अनुहार त छैन
हो त्यस्तै थियो भाइको पनि मेरो त्यस्तै छ वंशानुगत कि यसो अगाडि
भाइको पनि यस्तै छ भाइको पनि यस्तै छ
मेरो भाइको पनि
अनि
त्यस्तै छ
यो सेतो सेतो भयो कति भयो
यो दुबी जस्तो आएको कति भयो बुवा हाम्रो यो
खै यो 2 वर्ष आएको त धेरै भयो 27 वर्ष हो कि
त्यही आशा
8 वर्ष 67
पेट देखाउनु त पेटमा पनि दुबी छ कति कति है
पेटमा त धेरै छ